very interesting case because it was a 80 years old female with a history of bilateral breast cancer, bilateral radiotherapy. So she had thorax, thorax. So the indication of TAVI was very, very important. So we had a patient with aortic stenosis and also with a severe dynamic subaortic gradient. In the EKG, we saw that the patient has a sinus rhythm and also didn't have any predictor for disturbance conductance. The coronariography, the patient had not severe lesions, but she was very symptomatic for angina. In the measurements of the annulus, we can see that the annulus was very small. Mean diameter of 20.25 millimeters. The perimeter was 63, and the perimeter driven diameter was 20.8. It was a small annulus. If we think about the annulus is for a 26 millimeter valve, but if of the patient was very small with the mean diameter of the sinus of Valsalva was 25. So we choose for a smaller valve. And on the other hand, the coronary height was good enough. We did this case with HEMMAL, unfortunately. Put the next slide, Juan. The vascular access are okay. So we're planning to conscious sedation, femoral access by the right femoral artery. We're planning to perclose with 2 ProGlide systems. We planning to use the radial access as a secondary access. We use confida wire, as you were talking, because the ventricle was very, very tiny. So we choose a confida wire. And we thought that the predilatation with a non-compliant balloon 18 was the best thing. And then we try to avoid pacing wires, put a pacemaker, transitory pacemaker. So we use wire pacing. And we use also Evolut 23. Let's move to the case. So we are watching that we did a femoral puncture guided by echo ultrasound. You can see the both profunda and superficial, and now the femoral common artery. And we did the punction guided by echo. Then Hemal, if you want to help me with this, yeah. we select the optimal projection.
Yeah, so we flew by on the CT scan reconstruction, but we already had an idea of what this would look like, right? So we had used the software that you had, the ProSolve software, to get the actual view that we were going to use, which isolated the non-coronary cusp and overlapped the right and left. And so we used that view. And this is the skill that you can get from being Matias, and that's awesome. But the point is here we had the cusp overlap view, and actually creates a very easy angle to actually cross the aortic valve, because all you have to do is just aim right to the right of the pigtail catheter, and you'll get it every single time. And so literally he was able to cross this valve. It usually takes him about 10 seconds. He took it 3 seconds this time around.
And another important thing was, do you remember the ventricle was very, very excited? So we had to move very fast because the small cavity was very, very excited. You can see there the aortic gradient and also the dynamism of the aortic gradient. So the patient was very, very hypotensive in this case. So we moved quickly to put the valve without predilatation. So once we cross the valve, we put the confida wire. Then we move very quickly to the point of deployment.
Hemal, any comments on that, on the following steps?
We had some ectopy, and so, we decided to directly deploy. I didn't think that we necessarily needed to pre-dilate, so this was fine. We came across the aortic valve plane in more of a, in the cusp overlap view. And as we kind of get down to the point of the annulus, we're going to basically see that the parallax is essentially gone out of that marker band, and we're really going to start our depth of deployment right around mid-pigtail. And as soon as Matias got to mid-pigtail, I'm like, stop. And we stopped right there, and then we started to slowly unfurl the valve. And so here, Matias and I are kind of talking to one another. We've got the wire in very nice place towards the apex. We get up to the third node of the valve. We pace at a rate of 180. Her blood pressure was a little soft, so we really need to pace at a high rate. So we got up to the point of no recapture at a pacing rate of about 140. We're going to get about a 2 millimeter depth of implantation in comparison to the non-coronary cusp pigtail there. Now we're going to pace down by ramping down the pacemaker. So we go to 120, 100, and then off. And then once we get off, you'll see that basically the conduction system is completely fine. We're at about a 1 to 2 millimeter depth of implantation on the non-coronary side there. And now we're going to, after this aortogram, we'll rotate LAO to take parallax out of the valve and understand where we are in relation to the left coronary cusp to make sure that we caught it. You can see that our delivery catheter is more towards the outer curvature of the aorta here. So this is one where, again, we're super shallow on the left, but I like where we are positioned right now. And this gives us a lot of information. Now I'm not going to tell Matias to do anything to the delivery catheter. He's just going to hold steady on the delivery catheter. And once we hold steady on the delivery catheter, the valve should not move at all. And so in this particular case, we left it right where it was. We pulled the wire back so it was barely out of the nose cone. And then we did a 30-second deployment or release of the valve, the tabs. And here, Matias is not doing anything except for just holding on to the delivery catheter.
Exactly. This is a very important tip. Once you have this position, you don't have to push anything, because if you push, maybe you are going to pull the prosthesis up. So you have to do nothing. And another
so we're observing, making sure that all the tabs are off here. Then the next move is just to basically ensure that, again, everything is free. And once we're sure that everything is free, we're going to check our hemodynamics.
It's very important in these maneuvers, try to put the focus and put the eyes in the nose cone, to try to do not put the nose cone in the lower part of the valve and pull the valve out, no?
Right, and so this is an advanced move here. I like this. Obviously, we do this a lot at our center, and Matias is now doing it as well. We like to take the wire out of the delivery catheter here. The nose cone, as you can see, is partly in the valve frame and partly below. And what this will allow us to do is actually get hemodynamics. So we hooked up the delivery catheter, we got hemodynamics, we put the wire back in after that, and then we take the whole thing out. And being very careful to make sure that our nose cone is not entangling with the valve frame. And we do that just by, again, some manipulation on the delivery catheter, some manipulation on the wire, just making sure that we're nice and free. And then we get back to the descending aorta, recapture the nose cone, and then we're ready to go. And then that's our aortogram at the end. Now that is done in an LAO projection, so it really is not going to tell you depth of implantation. It's just a nice looking aortogram, and obviously we had no leak. We had great hemodynamics with 23 millimeter valve.
The most important thing in this case was to select the optimal projection view that was made by Oros. HON is a free software, so everybody can do it in your own CAD lab.